I'm Jayda Jun. I'm the neonatologist from Cleveland Clinic Children's Hospital. And our speaker today, it is my pleasure to introduce our speaker, Dr. Gorm Greisen today. So he's an emeritus professor of pediatrics. He was the chairman of the Danish Council on Ethics and chairman of pediatrics, University of Copenhagen. He is currently president for the European Society for Pediatric Research and International Pediatric Research Foundation. His research interests are neonatal brain perfusion, oxygenation, brain injury, and neurodevelopmental deficits and perinatal growth. He is coordinating investigator in the SafeBoosC-II project, clinical coordinator of the NeoMIM project, and steering committee member in 4 European research and educational projects. He has over 400 publications on PubMed and over 10,000 citations. He has taught over 30 PhD students. He is the 2022 European Society Pediatric Research winner and Knight of the Order of Dannebrog, which honors and rewards the faithful servants of the modern Danish state for a particular contribution to the arts, science, or business of life, or for working for Danish interests. Dr. Greisen.
Thank you so much for the kind introduction. I'm no longer current president of anything. I'm sort of living on my pension, and then I'm sort of trying to contribute. I'll address the issue whether by measuring cerebral or monitoring cerebral oxygenation can improve neonatal outcomes. And to take the tension off, I say the current evidence is probably neutral, or we have little evidence that we can. First, a bit of I call it a sentimental journey because I've been in this field since mid-80s. Already in 1977, Jöpsis described it was possible to irradiate near-infrared light, so light which is of longer wavelengths than the visible light, but shorter than infrared light. That was possible to radiate that through the head of an adult American, and this was relatively rapidly picked up in neonatology, and the first publication was in 1986. So very basically, you shine light through a light fiber coming from a machine here with a laser, and then you, in this case, shine it through the head of this relatively large newborn infant who is mechanically ventilated. And the light goes in from the source, and because of the nature of photons, it will scatter all over, and those photons who go deep, they will never come back, and those who go shallow, they will escape to the surface. So what you see here, the detector level, is photons who statistically have traveled in kind of a banana shape. And the light sees hemoglobin, mostly hemoglobin in the vascular bed. Normally there are no hemoglobin outside the vascular bed. And because of the spectroscopy aspect, that different wavelengths have different absorption spectra for oxyhemoglobin here and deoxyhemoglobin here, it is possible by using light of different wavelengths to compute the saturation of this hemoglobin. All this is basic to many people, but I just repeat it for those of you who may not be conversant with it. And we had a local instrument, prototype instrument, built by the company Radiometer. And in '89, we did this study on a baby on a ventilator, and just increasing expiratory time here. So we were monitoring PCO2 with a transcutaneous electrode. And when expiratory time increased, the PCO2 started climbing up. And at that time, we measured cerebral blood flow by radioactive xenon clearance, which is a very robust method. And we got this measure for global cerebral blood flow at 6.8 milliliters per 100 grams per minute. And after a while, we repeated that measurement, and now it has increased from 6.8 to 7.5. And then here we increase again the expiratory time, and the PCO2 climbs up further, and the blood flow increases further. And here are traces from the, we call it continuous wave spectroscopy. So these are in a rather random units, but we see very clearly a parallel increase in oxyhemoglobin and decrease in deoxyhemoglobin, which increases even more, decreases even more when ventilators set again. So a very neat and predicted reaction of this new method. Now in 1908, well, the idea was put forward that it would be possible to do a spectroscopy at slightly different distances, called spatially resolved, because spatially this way. And by detecting light here at different distances, it was possible to calculate the slope here, and from a relatively small number assumption from that slope, it is possible to calculate the saturation, the average saturation of hemoglobin in that banana shape on a scale from 0 to 100%, just like for pulse oximetry. But this is tissue oximetry. That's why there's a T here. And this measure is venous weighted because most of the blood vessels here are, or most of the blood are in the veins, and little are in the arteries and even less in capillaries. And technology has evolved, so now it's possible to get these probes, so you just stick them on or with a bandage, hold them on a baby's head. So this has become a very convenient tool. So I decided I've got a bit of money to start a project where we asked the question, could monitoring of cerebral oximetry have clinical relevance? And that was in 2009. And here we had a European Neonatal Brain Club. So I was able to gather a number of people involved in this in different ways. And here in November 2011, we just got 1.5 million euros. So we were very happy. And one of the first things we did was to define what could you do if the brain is blue. I mean, if oximetry shows that saturation is too low. And I already spoke of PCO2. Many people will also be caring about blood pressure. So increasing blood pressure would maybe an idea, or increase the pumping of the heart, or increasing the erythrocyte, the hemoglobin in blood, or airway, either reducing pressure to improving the filling of the heart, or increasing pressure to improve the distending of the lung, obviously increasing the FiO2, and then there's the issue of the arterial duct. And then also in this project we were considering, because at that time oxygen toxicity was quite a concern, so we also considered what you could do when the brain was over pink. For a primary outcome, we decided to work with the burden of hypo and hypoxia. I put this in parentheses because it proved to be much less of a problem and much less manageable. And a burden depends on time as well as on degree. And this is imaged here. So this is the area under the curve under a certain threshold here set at 55%. So this is now cerebral or tissue oxygenation, dropping over time, increasing, dropping again, and here giving rise to a certain burden of cerebral hypoxia, and then increasing again. And this was, I got this slide from Petra Lemmers, who were part of the group, and this is 1 hour worth of monitoring in an extremely preterm infant. And here's a recording of the mean arterial blood pressure. So the changes here in cerebral oxygenation in this particular infant seem to be highly dependent on blood pressure changes, and most likely this is infusions of saline. We know this will help, but only the effect will only last some quarter of an hour or so. And in a randomized controlled trial where we compared open NIRS, where this value was visible on a screen and there was an alarm to alert the clinical staff, and this group was compared to blinded NIRS where the device was put in a wooden box, and the only thing the clinical staff could see would be that the machine was actually running, producing data. And when comparing this, this was were extremely preterm infants, about 8 in each group. it's quite clear that in the open NIRS group, there are fewer infants with a very high burden of hypoxia and hypoxia, and quite some infants with virtually no burden. Whereas in the blinded group, there are much more pronounced burden of hypoxia and very few babies who avoid it altogether. In that trial, although it was not powered for this, we also recorded clinical outcomes, and it was so that the risk of death or severe brain injury was decreased from 34% in the blinded group to 26% in the NIRS open group. So quite a promising result. But obviously, the study was not powered for such a thing, and therefore we needed to do a larger trial. And this was then the SafeBoosC-III trial, where we wanted to reproduce this finding. And statistics are so that this requires 800 plus 800 infants to do this with a power or a probability of showing an effect of 90%, which is standard for large randomized trials. For this, we were never able to get much money, so we had to partly run it as a very pragmatic trial. We were asking for very little data, but the central part, so the randomization and the data collection was done from Copenhagen. And we also were dependent on crowdsourcing. So the 70 hospitals who contributed to the trial had to contribute all the work, all the money for various, I mean, that may even be patient insurance in some hospitals. That would be for good clinical practice monitoring. We required a little bit of that. And then for monitors. Industry contributed in various ways, and the primary investigators in these hospitals were welcome to get help from industry, but obviously industry had no influence, neither design the data recording nor reporting of results. And contributing hospital range from US, Iowa, to Shenzhen, Shanghai in China. 1 in India, 5 in Turkey, but most in Europe. And in spite of the COVID crisis, we were actually able to complete in 30 months, not 24 months as we had hoped for. And first, the primary outcome was actually known for 98.6% of the infants. And that I think is pretty good for a trial of that nature. And next, the paper was with 108 authors, obviously, because we wanted to recognize the contribution from all hospitals. And then I will mention Matthias Løe Hansen, who was the first author. He was a PhD student and did a very, very systematic job to complete this. But then obviously the most important here is that the relative risk of the primary outcome was 1.03. Even a little bit above 1, meaning that the patients in the experimental group did a little bit less good, less well, as marked by dying before discharge or having severe brain injury by cerebral ultrasound as evaluated at the hospital. We did not have possibilities for do central evaluation. But remember, we asked people to do this blindedly, so every primary investigator had to find a colleague who would not know which baby was which when looking and scoring and evaluating and diagnosing the images. So now the sentimental journal, mixed feelings. Clearly satisfied to have delivered on the question we were asking, but also disappointed because this is probably 30 years of work for me, and it was promising. And the discussion from now will be, is it still promising? So first question, is hypoxia really important for the brain of extremely preterm infants? And this is a long discussion, and we could have this in many levels of detail. I'll just present first the principle. We know that there are many, many other causes of brain injury in extremely preterm infants, and the monitoring of cerebral oxygenation can only deal with this. And also from large effort of randomized controlled trial, not looking at cerebral oxygenation, but looking at pulse oximeter reading. You are probably familiar with this data. This was a prospectively planned meta-analysis of individual participant data from 4 different trials. And as you can see, the numbers are large here for the components of the primary outcome. They are sort of larger, twice as large as a SafeBoosC trial. And here the neural Bayley-III score less than 85, cerebral palsy or deafness. And there's really very little evidence that this is a primary major disability defined by conventional means, or motor deficit, mental deficit, or sensory deficit. There's very little evidence of benefit or difference between running a higher target range for arterial saturation or lower target range for arterial saturation. So I think this data suggests that hypoxia may not be such an important factor for brain injury in very extremely preterm infants. Then there is some technical questions. Is cerebral oximetry yet too inaccurate? And first, this is quite a complex slide, but I'll take you through it. It was reported now some more than 10 years ago. It is from a simulation. So first, manifolds, or you call it manifolds of brains of different individuals of different age was produced from MR scans. So here's an MR scan, and out of this MR scan, a model based on very small voxels, bits of tissue, was created in the computer, separating a superficial layer, cerebrospinal fluid, gray matter, and white matter. And then this goes for the newborn, the 6-month-old, 12-month-old, and the adult. And then simulated again what's called a frequency domain instrument with spatial result spectroscopy. So the source is here, the red dot, and all the detectors lined up here. So the simulation takes place in the sort of the computer. The one photon is issued and hitting a voxel, and then by the nature of that voxel, so the scattering index and the absorption index, that small voxel, it is decided whether that photon will be absorbed, disappear, or be scattered to another voxel, and in there decided whether it be scattered or disappear and scattered again. And then some of these photons will ultimately end up and be detected one of these. So, and it takes billions and billions of photons to simulate, and a lot of computer time, but it is doable to a very great detail. And it is sort of gold standard simulation of photonic. And here are results for this is from the different, here the different separations between the near and the far sensor. And here, the line here is the true absorption coefficient in the brain. And the light shines through a superficial layer, which always had a absorption coefficient of 0.1. So this is 1 in both, and here is less and here is more. And perhaps as understandable, these lines represent then the detected absorption coefficient. I'm sorry, I'm a little bit technical here, but this is photonics, and I think it is important or useful to understand it. So we really get a mixture of the superficial and the deep matter when we do it shine through the skin, from the skin. And this problem is of this magnitude here, and in the 6-month-old it is still pretty okay. At the 12 months it is quite okay, and I think perhaps even a little bit better. Perhaps there is an advantage of less cerebrospinal fluid for the 12-month-old, but in the adult it becomes pretty hopeless. So our adult colleagues using the infrared spectroscopy should really look at this curve. Also, it is clear that those at short distances perform considerably worse than those with long distances. So this was accuracy. Do we measure what we think we measure? Now, precision is about, do we measure the same thing every time we try? And this was a former PhD student of mine who she's just holding the detector and then reading and then reciting the detector and reinitializing the instrument and getting a slightly different value but very stable, and then doing the same procedure again and again. And you can see that just by lifting the detector and putting it back, you get a difference, which actually much larger than the difference you get once it is sitting there. And regardless of where you sort of sit it and let it sit for several days, it doesn't remove the problem that where you set it at the first time is random. And the number here is 5.2%. And for comparison, the pulse oximeter will have a precision of 2 to 3%. And in this same study, I think there is a finding which may help us enlighten this. And this is a particular scan where one side of the head here had very neat gyri and sulci, whereas the other side had an underdeveloped gyri, and that means quite a bit of cerebrospinal fluid here. And look at the effect on the reading of the near-infrared or the frequency domains instrument. Very much affected by this little bit of cerebrospinal fluid. And we know that in preterm infants, and particularly extremely preterm infants, they may have very large pockets of cerebrospinal fluid sitting over the central cycle, frontally, posteriorly. But actually, if you turn the baby over, the brain will tend to sink in the fluid. So this is not only anatomically defined, but it's also time dependent. So I think the major source of this imprecision problem is due to the optic heterogeneity. And then there is a technical issue that devices differ. First, I think we were the first to show this in 2014, cerebral oxygenation after cesarean section, minutes from umbilical cord clamping, 2 minutes to 10 minutes. And we see this not a re-oxygenation, but oxygenation into the normal atmospheric air in a normal, healthy term infant. And that has been seen in many studies. The important thing here is that we actually use 2 instruments, an INRS on one side of the head and a foresight on the other side of the head, and we vary right and left among the infants, 30 infants altogether. And there's a very clear difference. So here at 70, 65 is the 75 normal ranges, the difference is small, but at low levels, the difference is very significant. And also look at the scatter. So this is imprecise, and these 2 instruments even do not record the same thing. And we have reproduced this very clearly in a blood lipid phantom, published here in 2016. This is just a diagram. It's a closed box, and in here there's water and lipid and a little bit of blood. And this is a plot of a time course. So we have a little oxygen, that's light pink, and bubbling oxygen through the chamber. We have high saturations of the erythrocytes, which are swimming there in the lipid emulsion. And then we stop the oxygen, and then there's a bit of yeast, and the yeast will digest or use the oxygen, or burn off the oxygen, and then the erythrocytes will desaturate gradually. And then we rebubble and add some more blood, and then it takes a little bit longer for the yeast to digest, but then it will start dropping again, and then with more hemoglobin again, and a bit slower, but very, very reproducible, as you can see. And these instruments are very clearly different. And we also saw this in preterm infants here in 2019. Pulse oximeter, this is 1 hour monitoring time in an extremely preterm, a preterm infant with recurrent apnea. So just a day in the NICU. And here pulse oximeter drops from sort of the 90-something to 40, a deep desaturation. And the 2 oximeters, they show that very, very well. They are running at a quite different levels, not certainly rarely so different as they are here, but the drops are to a very different degree also. So this is just showing that even in preterm infants, we see the same difference among instruments. And this has actually led to, because us who were working with this got into the ISO standardization organization, International Standardization Organization, and worked hard to have a possibility of sort of demonstrating the characteristics of a cerebral oximeter by using blood lipid phantoms, and not only from desaturation studies in healthy volunteers, which was practice until then. And as you saw, a healthy volunteer, the brain and the way these instruments work in adults is very different how they work in newborns. So there's no question that we have a problem with oximetry. It's far from perfect, but there are other things to consider. And one thing which is clear, could we have the intervention well implemented 24/7 in 70 hospitals? Not all these hospitals were very sort of keen to, but they all joined the study out of an ambition, I think, to try to show, because I think this is the bias, try to show that it is helpful. But it does take time to become an expert. And in order to address this issue, we made a multilingual web-based training program. And this was actually presenting some teaching material, but also making clinical cases and asking a multi-choice between different appropriate answers to these questions, which were sort of daily life situations. And then the pedagogical principle was that whenever there was an answer, there was given a pretty detailed explanation why an answer either was right or was wrong, in the hope that we were doing these questions again and again, people will learn. And obviously the questions were shifted around, so there will be no sort of just remembering what I answered last time. And in the end, when the candidate has answered in the 3 different domains we wanted, then we would give them certification. And you can see here we achieved a nearly 50% certification rate by all the physicians who were involved in the acute care in these infants during the first 3 days of life where it was running. And while for the nursing staff involved in care, we only achieved 1/3. Yeah, and we recorded for every involved baby was in the clinical record a note that a management was changed due to cerebral hypoxia. Was that recorded in the clinical record? And that was the case for 28% of the cases in the experimental arm, clearly. And then we looked, this is in the publication, in the appendix. Here there are the 65 units with at least 1 baby in each arm. And you see that this is a standard forest plot, so this is not randomized. Well, it is, you can say, that because we actually did randomization by site, so you could consider the whole trial as 70 parallel clinical trials. And just looking down here, you see that there is very little evidence of centers doing either better or worse than the average, and the number estimating the heterogeneity was really very insignificant. Do we take questions now?
We can take the questions at the end of your presentation. Yeah, if it's okay for you.
At the end? Yeah,
yes,
then I'll continue. Well, last obviously is pathogenic. I mean, hypoxia, not hypoxia will make the brain blue, but hypoxia will actually kill brain cells or change the brain or injure the brain. Is that just rare? And that is related to the question, may monitoring help occasionally, just like seat belts for children or for adults. We put them on day out and day in, and most of us will never really experience that they help us. And this is what's called a Bayesian analysis, and we've just had a protocol for Bayesian, a formal Bayesian analysis of the SafeBoosC data published in trials. So this is just examining the question, could the effect be just a 1% risk reduction? So from 34% to 33.6%, just being helpful in 1 out of 100 babies. And I won't tie with some of this. This is the idea, and you have the two distributions. So this will be the distribution given the number of observations we have with a null effect, and this would then be with a sort of minus 1 out of 100 reduction. And the minus 1 out of 100 reduction probability is only 90% as probable as the null effect given our data. So this difference really means that there's very little evidence to say that it is more probable that that really doesn't make any difference at all than it is that it actually helps 1 out of 100 children. You can say that the precise estimate, the central estimate, is that it will endure 1 out of 30 babies. Personally, I think this is unlikely. I mean, we know we recorded severe adverse reactions. We had a few cases of skin injury, but come on, we wanted to know how many. There were 6, and we had no incidents where there was a report that attending to the sensor made a nurse or a parent or a doctor dislodge a tracheal tube, giving problems in reinstalling tracheal tube, or a catheter, or other physical mishap during the attention to the probes. And we had no record of doctors afterwards saying that the management decision taken on basis of a low cerebral oxygenation value was stupid or misguided. We were quite concerned. I was quite concerned about this because it is 24/7, and at night there may be people involved in clinical care who are less able, conversion interested, and may end up doing something stupid on basis of on the reading, and this would be the real potential for harm. The light itself is really, I can say, from physical considerations, impossible to do a heating of any significance. So what to do? I found this. This is a US translation or rewriting of a Hippocratic oath, and it is stated you should avoid those twin traps of overtreatment, which is a big problem in medicine, and overdiagnosis and overtreatment, and the other thing, which is therapeutic nihilism. So we should avoid both. So what to do? And my personal bias is that we should not disturb unless necessary. As neonatologists in neonatal intensive care, we are already impinging greatly on the life of that small patient and on his parents. And this particular baby is on nasal CPAP. He's on the chest of his father. There is probably very little we would be inclined to do should the recording show a slightly low value. So I would personally say, leave him alone. No, don't leave him alone, but spare him another sensor, another light, another thing for the nurse to work with, and the doctor to discuss, and the father to worry about. But there are certainly other patient groups and situations. Now, in my center, we also do ECMO, and here, I mean, there are so many machines, and the only thing we don't monitor, well, we do what we call EEG routinely on these babies, but we could also have a NIRS sensor sitting here, and that screen would not be sort of a dramatic increase to the technicalities. And you could say that there would be more risky situations. So, just do it, or do we need more randomized controlled trials? And I think that's up to each of us to decide whether we say that we are never going to prove benefits. So this makes a lot of sense. I mean, come on, there's so many things we do where we don't have any sort of evidence from randomized controlled trials. And here, SafeBoosC trial have shown that there is very little, there were very few severe adverse reactions, direct complications, and the biology and the physics is such that we cannot imagine that we simply cannot imagine that there would be some kind of strange molecular effect, side effect of this. Or more randomized controlled trials. And right now in the consortium or in the project, we are planning a trial in ventilated babies. More than 28 weeks, any ventilated baby, not with cardiac problem, because I think we can't get our cardiologist colleagues to abandon it, and not with babies with known brain injury, because this brain injury already pre-existing the intervention will sort of make it more difficult to demonstrate an effect. So please check this homepage, because this is where we put our progress as far as we make it. And if you want to join, let us know. Another way forward would be smaller steps, not the big question, does it help, but the smaller steps in how does it work, what does it change. And I drew up this a little bit, this confusogram, which is a directed graph. It is unfortunately not an acyclical graph, because there are several feedback loops, positive and negative, which makes it very difficult to predict from observational data where you will, what kind of effects you will see. It is here on this, and it's free for everybody to open it and change it, but you cannot store it. You cannot store your changes, or perhaps you can copy them. It's an open access facility. Just the PCO2 effects. I showed this previously. So here the PCO2 is out here, and it works on, we know, on local blood flow, and we would predict that this local blood flow works on the end capillary hemoglobin oxygen saturation, which is what we try to measure with NIRS. And we do not think that it will change metabolic demand. So we just did a study out of a European project called BabyLux, and the work was done in Milan. And the paper is in press in neurophotonics. And this is a change in PCO2. This was mechanically ventilated, relatively not so preterm or even term infants who were stable on the mechanical ventilation. And we just dialed the ventilator a little bit up or down according to whether the PCO2, which was taken just for clinical reasons, were a little bit high or a little bit low. And then we just measured over a period of time, half an hour approximately. And these are individual infants, and you see as expected that when you increase the PCO2, the cerebral oxygenation will increase. And the same thing, more or less, the tissue oxygen extraction will drop. This device also had a NIRS-based flow meter. I'll not explain that, but this exists. And that showed, this is a logarithmic scale, and already here you can see a big problem that there are large, huge absolute differences in this measurement. So there is an imprecision and most likely an inaccuracy in this method. We would not at all expect blood flow to range over an order of magnitude. But we see the same increase as expected, and for the metabolic rate of oxygen, we see a stable value as we predicted, or perhaps a small increase, but very minor increase. So basically, this results show that you can rely on this increasing tissue oxygenation. This really represents an increase in blood flow, as we would expect. Then there is a question of hemoglobin concentration. We do a lot of transfusion in neonatology, and there's a long discussion of what threshold should we use and what patients should we transfuse. And here the idea is that we want, with more blood, with a higher hemoglobin concentration, we want to increase the end capillary hemoglobin oxygen saturation, and that this end capillary PO2, that will really improve the mitochondrial PO2. So that will translate into a benefit to oxidative phosphorylation at the cellular level. And this is unpublished data from another PhD student of mine. This is in piglets. Oh, it's the cursor stuck. This is in piglets, and these are 4 hours and baseline, and then transfusing hemoglobin, erythrocytes, and then an exchange transfusion to take them back, and then another exchange transfusion to produce a low hemoglobin concentration, and then another transfusion, exchange transfusion to put them back. And in each state, we did a desaturation just by adding nitrogen to the respiratory gas. And here we have cerebral blood flow, mean arterial blood pressure, and total hemoglobin. I think all this is pretty much as predicted. And we could monitor EEG, and the question was, at what stage of this desaturation would EEG be affected? EEG as a measure of oxygen sufficiency of neural cells. And first, we showed that venous saturation, because in a piglet it is possible to put in a cannula in the sagittal sinus vein. There is a fontanelle, and you can put in a 25 French cannula. And as hemoglobin was higher, the venous saturation was higher. So it is apparently true what we see with near-infrared, has seen with near-infrared spectroscopy in many studies, that with higher transfusion increases the cerebral oxygenation. So that was confirmed here. And here we see it by the near-infrared spectroscopy, by this time domain instrument. And blood flow decreased a bit. This was measured again with near-infrared. And what was a bit surprising was that the metabolic rate of oxygen increased, because these piglets were sort of clinically stable. Okay, down here we know that when a piglet really gets hypoxic, then it will decrease cerebral metabolic rate. But why this should be, so we are a little bit in doubt how to interpret this. But most interesting here is, if you look here at the blood values from the co-oximetry from the sagittal sinus, we actually found that subelectrical failure, precisely the point where the EEG started failing, was lower with a higher blood hemoglobin. So being anemic here means that there is less resistance towards hypoxemia. And I think this could be, that is important, although now large randomized trials demonstrate that there is really no clinical benefit of transfusing preterm babies earlier. But I think this kind of information, this kind of pathophysiological information, may be small important bits of information to judge what to do. Yeah, that was it. Thank you.